I'm honored to have been invited to take place in this meeting. Thank you very much for the invitation. Dear colleagues, dear Chairman, what would be the key challenges in the field of kidney transplantation today? According to the fact that the prevalence of chronic kidney disease increases every day, one of the major problems in the field of kidney transplantation is shortage of organs. Short-term graft survival is, you will agree, close to perfect, but long-term is still a challenge. A challenge is to allocate the best kidney to the best recipient, to minimize the ischemia time, to minimize the impact of surgery and the unwanted side effects of immunosuppressive therapy on graft survival. Transplantation of sensitized patients is not just a challenge. Their accumulation is actually a growing problem in the transplantation today. Sensitization can be defined as a development of antibodies to the human leukocyte antigens, HLA antibodies. If those antibodies recognize donors' antigens, we call them donor-specific antibodies or DSA. Otherwise, they're non-DSA. Their presence is associated with higher risk of acute rejection, graft dysfunction, or worse, graft survival at all. They can be induced by previous blood transfusions, previous pregnancies, or previous transplantations. And the biggest chance for sensitization is a history of prior transplantation. HLA antibodies can be detected or measured through different immunological techniques. The oldest one is percentage of panel reactive antibodies, PRA, measured by CDC or complement-dependent cytotoxicity. If a patient has PRA higher than 85%, that patient is considered as a highly sensitized patient. Higher degree of sensitization means higher probability of a positive cross-match. CDC cross-match detects only complement-activating HLA antibodies, but flow cytometric cross-match has ability to detect even non-complement-fixing IgG subclasses, IgG2 or IgG4. Transplantation with positive cross-match, either CDC or flow cytometric cross-match, is defined as HLA incompatible transplantation. Then recently we have single antigen beads. They're more sensitive, they're CDC or flow cytometric, for detection and identification of HLA antibodies and DSA. The degree of antibody is expressed as MFI, mean fluorescence intensity. And although there is no general agreement on the value, as a significant MFI is considered MFI higher than 1,000 to 1,500. And finally, we have some new parameters important especially for large organ donor populations: virtual PRA, calculated PRA, and calculated reaction frequency. They actually calculate or estimate the chance that a patient has HLA antibodies reactive with a donor from the actual donor organ population. So, progress in transplantation, in kidney transplantation, as a consequence or as one of consequences, has increased the number of sensitized patients. Improvement in immunologic techniques allows us to detect all that antibodies. Bigger number of kidney transplantations mean growing number of patients who are candidates for retransplantation, and according to the study's data, at least 35% of them are sensitized. Aware of this problem, European Society of Organ Transplantation convened a working group with the aim to improve transplantation of sensitized patients. They, among other things, proposed algorithm for transplantation of sensitized patients. And I would like to mark three things here. First, if the patient doesn't have a living donor, prioritization on waiting list is very important, such as acceptable mismatch as it is done in Eurotransplant. If the patient has a living donor but unacceptable because HLA mismatches, Kidney exchange program must be offered as the first step, first offer for these patients. What about USA? In USA, in 2014, a new deceased donor allocation system was implemented. And this allocation system increased priority of sensitized patients on waiting list for transplantation. Patients with calculated PRA between 80 and 84 received 2.5 allocation points, while patients with calculated PRA higher than 99.5 received even 202 allocation points. But few years later, results of the study showed that this was very effective for highly sensitized patients. Unfortunately, very highly sensitized patients, those with actually 100% of calculated PRA, continued to be transplanted at a very low rate. Dr. Shinstrup from Mayo Clinic and her associates in Rochester analyzed the waiting list and the sensitized patients on waiting list for kidney transplantation. And the results of their analysis showed that patients with CPRA higher than 80% were younger, were more likely female, were more likely on dialysis and for a longer time on dialysis, and were likely more had a prior kidney transplant than patients with calculated PRA lower than 80%. When they analyzed outcomes of 100 CPRA patients, they concluded that even 5.5 candidates on the waiting list had calculated PRA of 100%. Even 16.3 of them, not even, but 16.3 of them received transplant during the first year of follow-up. 6.6% were removed from the waiting list. Unfortunately, 4.3 died, and the 17.1% were made temporarily inactive. So after all these facts, if the question is, are the sensitization protocols needed today? I think that the answer is yes. Despite having a high priority on waiting list, highly sensitized patients rarely will receive kidney against which they don't have DSA. Consequently, they will require transplantation across HLA barrier, and consequently, they will require desensitization therapy. Then, results of the studies suggest that outcomes of DSA-positive transplants are comparable to DSA-negative patients. And the patients, finally, who received HLA-incompatible kidney transplant after desensitization therapy have improved survival if they're compared with patients who remained on dialysis and are comparable with them. Benefits of desensitization will even be bigger if we take into account, for example, blood type of the candidate for transplantation, if the candidate has B or O blood type. Then if we take into account waitlist mortality, potential removal from the list, or candidate age. If we talk about living donation, then desensitization protocol will offer all benefits of getting a living donor transplant if it is compared to deceased donor transplant. Then it can offer an avoidance of waitlist mortality and morbidity, and finally, dialysis can be avoided at all. European guideline for the management of kidney transplant patients with HLA antibodies recommends to start as a desensitization protocol with plasma exchanges or immunoadsorption together with IVIG or B-cell depletion. And today, protocols that include plasmapheresis or immunoadsorption, followed by low or high doses of IVIG, have become standard of care. But what other drugs do we have as desensitization drugs, or what other drugs are subject of clinical trials for desensitization protocols? We can talk about anti-CD20 antibody or rituximab, well-known rituximab. Alone didn't prove efficiency for reducing DSA, but in combination with IVIG, yes. Then proteasome inhibitors like bortezomib, indicated in treatment of multiple myeloma, can be efficient with standard of care protocols. Then we have inhibitors or antibodies to components of complements. Everybody knows, for example, eculizumab, anti-C5 monoclonal antibody, but this drug didn't show perfect effect as a desensitization drug. Maybe it can be explained by donor-specific antibodies that do not fix the complement. C1 inhibitor is the subject of clinical trials, and theoretically, this drug may be better than C5 because it stops activation of complement higher, more proximally in pathway, and so it will prevent more unwanted effects of complement activation than C5 antibody. Imlifidase currently is the only approved therapy to use in EU for desensitization highly adult sensitized patients with positive cross-match against available deceased donor. Anti-IL-6 receptor monoclonal antibody, or tocilizumab, we met this drug very well during the COVID. This drug has been successfully used in combination with high dose of IVIG or anti-CD20 antibody. Maybe anti-B cell activating factor together with standard of care protocol will be successful as a desensitization drug. If we summarize, we see that all these mentioned drugs have 4 places to act. They have actually 4 targets places for their action, and those are B cells, plasma cells, antibodies, or a component of complements. And finally, when we decide, yes, we need a desensitization protocol, when is the best time for desensitization protocol? If we talk about living donation, an early pre-transplant desensitization is absolutely preferred, and it will be continued until negative CDC or flow cytometric cross-match. Talking about deceased donors, 2 strategies can be applied: the immediate pre-transplant desensitization or the post-transplant desensitization. The first one, protocol, is used successfully in Austria. They use immunoadsorption followed with ATG or rituximab. And they showed that with this desensitization protocol, graft survival rates at 3 years are similar in CDC positive and CDC negative cross-match patients. Post-transplant desensitization has been used successfully in Necker Hospital in Paris for 21 years. They use ATG as induction therapy. Then it is followed by high doses of IVIG that repeated every 3 weeks for 4 courses, 5 to 10 plasma exchanges, and at the end of plasma exchange therapy, they add 1 or 2 rituximab. And the authors from this hospital showed that with this desensitization protocol, in the sample of 95 patients who had MFI higher than 3,000, 7-year allograft survival was even 78%. So we concluded when. Another question is to whom? It is very important to clarify who would have the most benefit from desensitization. And I think that we have to think about future studies and the patients who will be candidates for that studies in the future, because we will have more sensitized patients, absolutely. Doctors from, again, Mayo Clinic Rochester think that all kidney transplant candidates with practically 100% calculated PRA are candidates for desensitization. Then candidates for desensitization are kidney transplant candidates with CPRA higher than 98%, with HLA incompatible approved living donor who did not receive a kidney after 1 year in kidney pair donation system. And finally, kidney transplant candidates with calculated PRA higher than 98% who did not receive kidney after 5 years on kidney weight, list for allocation weight system. And authors also suggest that even a mild reduction in CPRA would markedly increase the rate of transplantation. So that is, again, accent on the needed for desensitization protocols. And if we at the beginning talked about challenges in kidney transplantation, I think that a major advance in the field of kidney transplantation will be a method for permanent reduction of HLA antibodies. Thank you.